All right, local protocols. So begin transport whenever the following occurs. If the patient does regain a pulse, throw them in the ambulance. 6 to 9 shocks have been delivered or as directed by local protocols. The device indicates 3 consecutive messages separated by 2 minutes of CPR and no shocks advised or directed by local protocols. Special circumstances in cardiac arrest. Cardiac arrest may require the paramedic to adjust treatments, procedures including associated with morbid obesity, anaphylaxis, opioids, acute asthma, and electrolyte disturbances. Post-cardiac care, begin by optimizing oxygenation and ventilation. Achieve and maintain SpO2 of 94% or higher. Avoid hyperventilation. We don't want to breathe too much, too fast for the patient and get it in their gastric, in their stomach. Obtain a 12-lead ECG as soon as possible to determine whether acute ST segment elevation is present or STEMI. This is going to tell us if there is death of heart tissue or ischemia. Perform neurologic assessments through signs of hypoperfusion. Administer fluid bolus 1 to 2 liters of normal saline or lactated Ringer's solution. If the patient is marked by hypotension and the transport time to the medical facility will be prolonged when considering, then consider administering a vasopressor. Could be dopamine, could be epinephrine, could be norepinephrine. If the rhythm is bradycardic or tachycardic, then follow bradycardia or tachycardia algorithms, which we already went over. Start targeted temperature management after cardiac arrest for comatose adult patients with ROSC. So this involves maintaining constant target body temperature between 32 degrees Celsius, 89.6 degrees Fahrenheit, and 38 degrees Celsius, or 100 degrees Fahrenheit, for at least 24 hours. We're going to do a rapid infusion of cold IV fluids that was formerly recommended, but not any longer. Closely monitor the post-cardiac arrest patient. So when to stop CPR? The American Heart Association recommends that rescuers who begin CPR continue until one of the following occurs. Effective spontaneous circulation is restored. Care is transferred to a team providing advanced life support, and the rescuer is unable to continue because of exhaustion, environmental hazards identified, or because continuing the resuscitative efforts places the others in jeopardy. If you went out last night drinking because you were irresponsible and now you're too tired to do CPR, then that's on you. Criteria indicating irreversible deaths that have been met. Criteria of obvious deaths have been identified, or criteria terminating resuscitation have been met. Obvious death, decapitation. Actually, I think that's one of these. When the patient does not respond to pre-hospital cardiac arrest treatment, it is acceptable to cease efforts because ALS providers are capable of performing initial resuscitation equivalent in an in-hospital resuscitation attempt. There are no additional benefits to emergency department resuscitation. CPR performed during patient packaging and transport is much less effective than CPR administered at the scene. You have everybody there, all hands on deck, you have lights, you have controlled environment, you have AC, and yeah, it's way easier in the ER. Continuing resuscitation in futile cases places other motorists and pedestrians at risk and increases the amount of time during in which the EMS crew is unavailable for other calls, impedes emergency department care of other patients, and incurs unnecessary charges from the medical facility. That seems very irrelevant. The AHA, American Heart Association, has published criteria for BLS, ALS termination of resuscitation for adults out of hospital cardiac arrests. In some jurisdictions, state legislation will be required to permit pronouncement of death at a scene by a paramedic. Gaining permission to stop CPR in the field involving delicate issues. So expectations of the patient's family, disposition of the body, pressure from bystanders, paramedic unaccustomed to telling a family that a patient is dead. Atrioventricular blocks. The SA node initiates impulses in which, it's kind of weird, they just threw us back. I feel like blocks should have been way back when. But to the atrium and the vessels, resulting in heart contractions. Occasionally, impulses are delayed more than usual or are completely blocked, causing AV blocks. All right, so our first degree AV block, this is going to occur, so automatically, if I'm looking at this rhythm and I'm first degree AV block, I'm gonna look at the P wave and the QRS. QRS, P wave. P wave is pretty far back from where it should be relative to the QRS. So we have 1, 2, 3, 4, 5, 6. Like we have a number of squares here as far as distance go, and that's going to be our main sign that tells us there's AV block. Okay, so this occurs when each impulse is delayed slightly longer than normal, resulting in a constant PRI that exceeds 0.2 seconds. So let's count them. Every square is 0.04, right? Tiny square. So 0.04, 0.08, 0.12, 0.16, 0.20, and then 0.204. So we're above 20, we know that there's an AV block. Considered least serious type of block, but is often first indication that there's damage in the AV node. Usually regular with minimal with variations between the R-to-R intervals, and regularity depends on the underlying rhythm. An upright P wave is followed by a QRS complex varying in size and shape. So PRI is 0.20 seconds or greater, constant in duration, very consistent. It's going to be doing the same thing. QRS complex, nice and tight, 0.11 seconds, that does not change. Rarely treated in pre-hospital settings unless associated with symptomatic bradycardia. Second degree AV block, type 1. This is also called Mobitz type 1 or winking block. I saw this in a video. So think about winking block, you're winking, right? You wink with one eye, winking block. Type 1. Second degree, but type 1. Second degree, type 1. I had to say that over and over again because you're going to get these mixed up at the beginning. I still do. This prevents the impulse from proceeding to the ventricles and generating a QRS complex. The intervals between P waves is regular and upright. P wave precedes most QRS complexes. Yeah. This is all over the place. Okay, let's keep going through. The ventricle rhythm is irregular with a prolonged R-to-R interval between the last QRS complex before the blocked P waves and the QRS complex after the first unblocked P wave. I gotta reread that. The ventricular rhythm is irregular, okay? So ventricle, QRS, you can see right here, R to R interval. Well, that's obvious, that's really wide. That's almost the same as this, but maybe it's different, and then it's wide again. There we go, irregular. With a prolonged R to R interval between the last QRS complex before the blocked P wave. Okay, so this is the one that it's longer, goes away. But it's kind of hard to see that. So let's start here. I don't know, the T wave's doing like a double thing right here. It's throwing me off. Okay, so I guess this is supposed to be the P wave. That's what it is. It's not a double T wave, it's a P wave. So you have your T wave and then a P wave, but after the P wave, there's no QRS. There is none of this. It blocked, it went away. Then it starts over. So we have a P wave here. It's pretty far back, just like in the first degree block. Far back, QRS, T wave. All right, P wave, still pretty close. QRS, T wave, P wave, pretty far back. Goes up. Yep, still P wave. We still get QRS, T wave, P wave. Oh, there is no QRS here. So that is first degree Mobitz 1 winking block. Yeah. The key to recognizing second-degree AV block type 1. We're going to observe that there are more P waves than QRS complexes. So if we count the QRS complexes, those are the most obvious distinct symbols. QRS, 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 QRS. 1, 2, 3, 4, 5, 6, 7, 8. And then let's count our P waves. Don't confuse them with the T waves. We have 1, 2, 3, 4, 5, 6, 7, 8. 9, 10, 11. So we have 3 more P waves than QRS complexes. We lost 3. Increased vagal tone, digoxin toxicity. These are all potential causes of this. I think I skipped ahead. Noticing P waves occur at regular intervals. Okay, let's see if they occur at regular intervals. You have a P wave here. It looks like 1, 2, you could almost say it's like almost 2 large squares. So P wave, almost 2 large squares, almost 2 large squares, almost 2 large squares. Yeah, they're pretty regular P waves. Recognizing that the PRI associated with the conductive P wave gets longer until a P wave appears that is not followed by a QRS complex. Recognizing a PRI associated with a conducted P wave gets longer. Yeah, it's hard to tell. This is a bad example as far as seeing it get longer and get longer. Like whenever I'm taking my test, you can tell, obviously, whenever it gets longer with each PRI interval. But this is a bad example in that case. Noting the irregular ventricular rhythm. So that's where we see the R to R intervals here are not the same, irregular. Causes. So there could be ischemic heart disease, starting a death of heart tissue, not getting oxygenation, acute inferior wall or right ventricular myocardial infarction on the right side here. Acute inferior, so instant and on the inside or on the right side of the heart. Increased vagal tone, digoxin toxicity, certain electrolyte imbalances, administration of certain medicines. Patient is usually symptomatic. If the patient develops a bradycardia, treat in accordance to your bradycardic algorithm. Okay, second degree, AV block type 2. I think this is one that goes away. Let's see. Mobitz type 2. For more serious, it is a more serious than second degree AV block type 1. Why? Because there are less QRS complexes. If there are less QRS complexes, the heart is not beating as efficiently. You're not getting as many beats per minute typically. Less blood is perfusing and things are starting to decompensate more. So more serious. Impaired conduction occurs within the bundle of His, or more commonly known as the bundle branches. So if we're looking at our heart, the center of the heart is the where the bundle branches are. I'm pretty sure it's the myocardium. I'm starting to get terms mixed up, but the myocardium is at the center. An intermittent block characterized by regularly occurring P waves and abrupt appearance of at least one P wave that is not followed by a QRS complex. Okay, so let's dissect that. An intermittent block characterized by a regularly occurring P wave. Let's see if our P waves are regular. P wave, 1, 2, 3. It looks like it's about 3.5. 1, 2, 3, 3.5. 1, 2, 3, 3.5. A little less than that. 1, 2, 3, 3. Okay, so our P waves are regular. Regularly occurring P waves, but then an abrupt appearance of at least one P wave that is not followed by a QRS complex. So P wave here, P wave, no QRS complex, very abrupt, I guess. P wave, QRS, none, 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 QRS. So whenever I'm taking my tests, I mean, I'm going into detail about it now, and now when I take the national, I'll definitely, I'll look at all of these things, but the most obvious signs whenever I was just taking my static cardio test is I know that it's not complete heart block because we have a certain number of QRS complexes. We at least have like 4 in this, which honestly, that's very little. You can almost, this is actually getting pretty close to complete heart block. But because there is not as many QRSs missing and you have a high number of Ps, I would cut this down to either complete heart block or second degree Mobitz 2 AV heart block. So if you cut it down to those two, at least you're 50-50, you're in the ballpark. Causes include ischemic heart disease, acute anterior wall MI, infectious heart disease, and a cardiac operation. Symptoms could be dizziness, fatigue, dyspnea from exertion. Syncope, could pass out. Emergency care may require use of transcutaneous pacing. We might have to pace this patient. Can progress into third degree AV block without warnings. There you go. You might get third degree is complete heart block. So you're headed that direction. Second degree AV blocks can occur if the pattern is difficult to determine if it is type 1 or type 2. When 2 P waves appear for each QRS, it is a 2-to-1 ratio AV block. When 3 P waves appear for each QRS, it is a 3-to-1 AV block. Okay. P waves appear for each QRS, 2-to-1. So 2 P waves for each. Well, it's kind of inconsistent. So let's see, we got 1, 2, that's 2-to-1. 1, 2, 3, 4, we got a 4-to-1 here. 1, 2, 2-to-1. Usually the QRS duration is a clue. So within normal limits, type 1 blocks. Usually longer than normal, we have type 2 blocks. Okay, so if we're looking at our QRS complex, I mean, it's kind of hard to tell with these actually. These still look nice and tight. But type 1 would be nice and tight at 0.11 or less, or 110 milliseconds. But if you could tell that these are longer, you know that you have a higher degree block. And then, okay, so the QRS complex, 0.11 seconds if or less if the block occurs above or within the bundle of His. Greater than 0.11 seconds if the block occurs below the bundle of His. Okay, so if we're wide, then we're lower in the ventricles, more, we're being more affected in the lower part of the ventricles now. It's like, imagine the heart, if the problems are occurring, the lower into the heart, you're getting closer to the core of the heart that, the higher you are, the safer you are. The lower that the problems venture into the heart, the more insidious it's going to be. So the worse it's going to get. One way to think about it. Third degree AV blocks, also called complete heart blocks or complete AV block. It occurs when all impulses reaching the AV junction are prevented from reaching the ventricles and generating a QRS complex. So a secondary pacemaker assumes responsibility for impulse conduction. Look for non-conducted P waves and the absence of any relationship between P waves and the QRS complexes. So let's look for that. Non-conducted P waves and absence of relationship between the P wave. Okay, so the P waves aren't related to the QRS. There's no distinction between them. So you have a P wave here, QRS. That's almost borderline normal. T wave, P wave, nothing. This one's like right on the edge right here. It's just kind of firing. T wave, P wave, nothing for a little bit, and then you have a QRS, T wave, P wave, nothing, P wave. It's very chaotic, absolutely chaotic. And we have 4 QRSs here. Yeah, so at least in the last Mobitz 2, AV block 2, the P waves were consistent. But right now, they are all over the place. You're looking for patterns, and you're not even seeing patterns. Where was I at in here? Okay, it usually has a rhythm with consistent P to P and R to R intervals. So it's at least regular on your R to R intervals. So, this is a long jump, so let's see. 1, 2, 3, 4. Looks like 4 3/4. 1, 2, 3, 4, 4 3/4. 1, 2, 3, 4. Add 1/2 to 1, or 1/4 to 1/2. Yeah, 4 3/4. So your R to R interval looks regular. I guess your P waves are regular too, so we could count that. It's 1, 2 plus 1, so about 2.5 is our P wave. 1, 2-ish, it's kind of hard to tell there. 1, 2, 2.5, I'd say 2.5. You could just round up. So all of these things are clues that kind of determine that we're going to use in order to figure out if we put multiple things together, then we have complete heart block, or we have Mobitz 2. So patients can be asymptomatic, or symptoms include probably a lot of the same thing. Syncope, could be sudden cardiac death. It is treated in the field only if it's associated with bradycardia. Could also be produced by acute myocardial infarction, ischemic heart disease, and hyperkalemia, or too high of a dose of certain rate control medication. QRS complexes are wider than 120. Doesn't really look like the case here, but maybe. It's hard to tell because the screen's really light. Artificial pacemaker rhythms. An artificial pacemaker consists of a pulse generator. Wired electrodes are attached to one or more chambers of the heart. The pulse generator of a permanent pacemaker contains programmable hardware. It's implantable into the subcutaneous portion of the skin below the right and left clavicle. Causes a unique vertical spike on the ECG tracing. So we have what we call pacer spikes. That's what this is here. So everything here looks like a natural heart rhythm. Well, this is very bad heart rhythm. You don't want this. But we have the pacer spike that tells it what to do. That's that spike. That's electric activity. And it's very instant. That's why it's a spike. It's very thin. It doesn't have like a, the speed of your cardiac cells, the conductive cells that have to get all the electrolytes to pass and cause a chemical reaction and stuff, that takes time, right? That's why this is wide. Like if this QRX complex right here, it's wide because it takes time for that to happen. And this one's not even normal, but that's why you see like distance between whenever it happens. But with this is technology. This is literally like an electric shock instantly happening. That's why it's a spike. Causes a unique vertical spike on the ECG tracing. A single chamber pacemaker, you have dual chamber pacemakers, AV sequential, and biventricular pacemakers. I don't know which is which. If I was gonna guess, I'd say AV, single chamber. Yeah, I don't know. Maybe it'll go into it. There are two types of rates. You have fixed rate pacemakers, seldom used today, generates a pacing impulse at a pre-programmed rate. And then you have demand pacemakers, so equipped with a sensor that generates a paced impulse when the patient's heart rate is dropped below a predetermined rate, usually 60 beats per minute. So the demand pacemaker is more of a fail-safe, and the fixed rate pacemaker is more of this is what is going to run you from now on. Sometimes there are implanted pacemaker malfunctions, and the type of pacemaker failure includes the following. So it could be failure to capture. Pacemaker spikes may be visible, but they will not be followed by a QRS complex. It could be dislodged wiring connecting the patient's heart to the pacemaker, could be battery depletion, could be ventricular perforation. Failure to pace indicated on the ECG by absence of the pacemaker spikes at an expected time. So the pulse generator could have failure, broken lead wire or dislodged lead, disconnected wire or cable, battery depletion, so failure to pace. Failure to sense indicated on the ECG whenever the appearance of the pacemaker spikes within the P waves, QRS complex, T wave, malfunction, in which the pacemaker competes with the patient's own intrinsic rhythm. So you're going to see the pulse generator failure could be broken lead wire again, or battery depletion, excessive high sensitivity setting. Take a break.